Good evening, everyone. We might make a start in the best interest of time. So welcome to our 5th echo session of our Enhancing Palliative Care series. This session will focus on the terminal phase and responsibilities after death, and will be presented by Dr Russell Shute. So I'll just share my screen. So got that. Okay. So my name's Leanne, and I'll be co-facilitating tonight's echo session with Dr Russell Shute. I'm the General Manager here at GP Partners and the Share Care Programs Manager. So welcome. So I'd just like to acknowledge the Kaurna people, who are the traditional custodians of the Adelaide region. We pay tribute to their physical and spiritual connections to land, waters and community, enduring now as it has been throughout time. We pay respect to them, their culture and to elders past and present. We would also like to acknowledge and pay respects to those Aboriginal and Torres Strait Islander people from other nations who live, work, travel and contribute on Kaurna country. So welcome. Our project is supported by funding from SA Health through the Palliative Care 2022 Grants Program, and as you all know, it is being delivered to you by GP Partners Australia. Just some welcome and reminders, and we go through this at each session. So just a reminder to introduce yourself in the chat, to let us know where you're joining from and your role. Your microphones are muted, but there will be lots of time during the session for any questions and discussion, and because we have a small audience tonight, even better for those that have joined us. You're welcome to use the chat function and to ask questions if you have any comments or are having any technical difficulties, but also feel free to raise your hand. The didactic session will be recorded and will be emailed to you within the coming week. And as always, that can be accessed by the GP Partners website, the Palliative Echo Session tab. Remember not to disclose any personal information during the session. And as always, we really hope that you enjoy and get some benefit from this series. The general format is that we follow the echo model, in that we have a general introductions and then the didactic presentation and then an interactive case-based presentation with further discussion. So we really do want you to be a case presenter. So those that are out there, if you could and would be able to submit a case, please let us know either in the chat, or you can just email me the case using the template that I've already sent out via the email advising of our sessions. Or you can access that template via our website, going to the link below, or just clicking on the Palliative Echo tab in the website. So as I said, tonight's didactic presentation is the terminal phase and responsibilities after death. It's presented by the very well-known and famous Dr. Shute. I add my little bit in there. And but before we do go ahead with that presentation, as always, we'll just go around the table so that my team can introduce themselves. So we'll start with you, Atif.
Hi, I'm Atif. I'll be providing IT support for tonight's session.
Hi, I'm Naomi, and I am project coordinator and website management.
My name is Julian Soriano. I'm a pharmacist. I currently work as an embedded aged care pharmacist, as well as a palliative care pharmacist with the Southern Adelaide Palliative Service.
And hi, I'm Russell. I'm a GP with an interest in palliative care, and I will be presenting this evening.
And then online, I think we've got, starting with Olivia.
Hi, Olivia, one of the, I never know what to introduce myself as, but a new palliative care consultant, I think, is the official line.
And then we have Andrew.
Hi, Andrew Noble, an extended care paramedic team leader with SA Ambulance.
Okay, and we're also very welcoming tonight that we have Dr. Emily Cooper from Flinders. So Emily, just introduce yourself.
Yes, hello. So I'm a palliative care specialist. Also work with Olivia, and I came to palliative care through a GP pathway. So I'm also a GP, but not practicing anymore. But thank you for having me tonight.
That's excellent. So I know that Emily has some information to be able to share, and linking to some research, I guess you can call it. But what we'll probably do is have Emily talk to us about that following Russell's presentation tonight. So stay tuned. So over to you, Russell.
Okay, thanks folks. I will just share my screen. You cannot share while somebody else is sharing. Okay.
So,
Have to de-share.
there you go.
Oh, there we go.
That was a simple button.
That was an easy one. So,
Can cope with that one.
desktop. Actually, work, Atif. Do that. What? Can we see it?
Yes.
Yes. Excellent. All right. Okay, folks. Everybody okay seeing that?
Yeah, looks good.
Okay, so this is a talk that's been developed over a few years and it's come out of GP Partners Palliative Shared Care program that I was lucky enough to be involved with Chris Moy and Steve Hobson. And it was in response to, I guess, common questions from GPs, particularly around how you deal with the terminal phase and some of the specifics around that, but also about some of the legalities about death certification, those kind of things. So it's a bit of an overview, and there is a bit of repetition from previous talks, but I don't think that's a bad idea, because talking about, you know, making plans and having things in place for the terminal phase, I think is important. So Chris Moy talked about some of this stuff. So it'd be a bit of a refresher. It's one thing to say is that terminal phase is a little bit different. I'm going to talk about that. We'll talk about withdrawing non-essential treatment. We've covered that in a previous talk as well, but I'll go over that again. The sort of management that is reasonable in the situation and how to be best prepared. And then what sort of duties and responsibilities GPs have after the person has died. So the terminal phase is not simply a linear sort of continuation of what's happened in the past. There are a whole lot of new challenges and difficult times for both the patient and their loved ones. And so I think Emily and Olivia would readily agree with this. You need to be adaptable and looking at changed goals of care as things deteriorate. And I guess the first thing is to recognise features of the terminal phase, and I guess this is a skill that probably develops over time, really. I think when you first come out of med school, it's not something you're particularly good at, but it's recognising that. I'll talk about that, and then how you help people prepare for that. So getting the family to understand what's going on, and then having carers and staff, if you're in an aged care facility or in hospice or at home, what is needed. So what you tend to see is the patient becomes more disconnected from their surrounding environment. So they get weary, weak, sleepy. They're spending much more time in bed or a recliner, or, you know, predominantly bed bound. They don't really want to be bothered by visitors. They can get confused, not always. They may have a little bit of agitation, not as interested in having food or fluids, may start showing signs of being more gaunt because they haven't been having their sort of normal level of nutrition, and unable to swallow. But it's still tough, and I think anybody that's been involved in this area for any length of time has been caught out when, you know, we've pronounced that the person, on being questioned by the family, we've sort of boldly pronounce that we can't imagine them living beyond 24 or 48 hours, and then lo and behold, they do a Lazarus. So one of the things that's important, I think, is to share the uncertainties. It's a deteriorating process, but it's an unstable and sometimes unpredictable. And being constantly open with the family about that is really important. The other thing is that things can happen quickly too. So a patient may appear to be kind of chugging along okay, but then die quite abruptly for various reasons, because they're so much more at risk of things like PEs and other things. So it's really important to maintain communication, and again, focus on, we talk about goals of care all the time, but it's an important thing to talk about. So is the person dying? So there are some things clinically that can help us make that judgment. And I guess very experienced people, certainly when I was working in Mary Potter, we would often say, oh, that person's got a good death radar. And I think some people are very good at it. They just know, often nurses with lots of experience, they just have this sixth sense almost. But there are certain things that will help you know whether somebody's going to die within a few days. And so here, there's a couple of things here. These are 5 general signs that suggest that death is going to happen within 72 hours. If you get a very weak radial pulse, urine output decreases, Cheyne-Stokes very irregular breathing, respiration with mandibular sort of movement, and the so-called, not a nice term, death rattle really, but thick sort of airway secretions that are not being sort of cleared like they normally would be. Then there are 3 neurological signs that predict death within a few days, and they are decreased response to visual stimuli, the neck can be hyperextended, and the drooping of the nasolabial fold, and then neurological signs within 24 hours. Pupils are not reacting. There's a decreased response to any verbal stimuli, a grunting sound through the vocal cords, and an inability to close eyelids. So you know things are getting very close when you're seeing those kind of changes. There we go. All right, sorry, dark humour with the Grim Reaper arriving there. So it's important, I've said this and I'll probably say it again, clarifying with the patient if they're alert and capable of talking, and with the carers and the family, what their expectations are, what's your situation at home or a residential aged care facility, making a plan for symptom management and providing really good information, and making sure that the lines of communication are open. But it is really important to get this right, and especially those of us that have worked in specialist palliative care units, certainly talking to social workers that deal with bereavement, it's really important that we get this right, because it can have impacts on subsequent, the process of grief for families. The basics of care: dignity and privacy, sensitivity. Hopefully, we've talked about advanced care directives. Hopefully that's been done by this stage, but you might be surprised that occasionally it isn't. I don't know whether Olivia and Emily have seen cases where they've seen people with very advanced disease that still haven't got an ACD, but hopefully that's in the minority. And also, I think with the uncertainty, encouraging people to stay, but also saying, give them permission to take rests, to look after themselves, to care for each other. Because you certainly have people that will just refuse to leave the patient's bedside, and that's not really helping them, because they get absolutely exhausted, and that can complicate things too, especially if the process of dying drags on. So the common symptoms, and again, we've touched on this before. I think Chris Moy talked about this. And the sort of things that I'm going to talk about, the SA Health, very good form that gives some ideas about pharmacologically treating these symptoms. So it's noisy breathing, pain, maybe nausea and vomiting, agitation, anxiety, and dyspnea. So we talked, I mean, we kept on talking about this in the shared care program. I think it's a fantastically useful thing to do if you're doing any palliative care, particularly important to have this up in an aged care facility, and most of the ones I've visited have got them there, which I think is good. But a really useful guide, a really simple guide to having anticipatory prescribing in place as people are approaching the last days of life. Now, hopefully, as I said, you would have, there will be signs that somebody's deteriorating to the point where you need to have these things in place, whether it be for pain, anxiety, nausea, and noisy breathing. And it is a relatively simple guide, and it makes it very clear, and that's on our website for everybody to see, but it's also searchable under Google, but I recommend that to everybody. Withdrawing medications, briefly touched on a previous talk, but I think it's sometimes overlooked. We might touch on that with Julian a bit later, involve him in the discussion, but often at this stage, a lot of oral medications either are not necessary or they won't be tolerated if the person's not swallowing. So when that happens, it's to be aware of possible rebound effects. Now, there's only so many things you can do about rebound effects, I suppose, but knowing that if you abruptly stop an antidepressant, well, certainly if we see that in a well patient in general practice, it's a pretty nasty syndrome of withdrawal that they can get. So understandably, in the terminal phase, it might cause some distress with agitation, possibly headaches. Beta blockers, you might get some tachycardia or palpitations. Nitrates might get some chest pain. There is an SA Health fact sheet on medication cessation, and I think we've got that on, but we'll double check that we have got that. The reality is, what can you do about these? Well, mostly the rebound effects can be dealt with either pain relief or a benzodiazepine for agitation, anxiety, or both. It may be that you just have to be aware of, anticipating you might need more of a dose if you're abruptly stopping some of these things. So here's some examples. I mean, some of these are quite specialised, so specialist palliative care units will do this. If you're stopping anticonvulsants, I guess in a GP situation at home or in an aged care facility, you're going to be using benzodiazepines. Certainly at Mary Potter, we would convert levetiracetam to subcutaneous. Antidepressants, same thing. We'll use benzos or opioid. Antipsychotics can be tricky if they've been on high dose long-term antipsychotic, and often then it's kind of phone a friend, really, get some advice about that. I think Parkinson's is a complicated, and I think sometimes specialist sort of area, and sometimes you will need some extra advice from either a palliative care specialist, such as the two lovely people online tonight, or your local palliative care service, or a neurologist. Diabetes, very common situation that we'll see, very common chronic disease state, and basically there's an acceptance that we just cope with much higher glucose levels. You still might need to use basal insulin in type 1s, and it's still not unreasonable to check blood sugars. For type 2, which is the most common situation, of course, you just stop monitoring, stopping the oral hypoglycemics. Implantable cardioverter defibrillators, that's a very important thing to be aware of. If somebody has one of these and has advanced malignancy or neurological problems, and it's predictable that they're entering the terminal phase, then they should be disabled, because if you don't, they can cause unnecessary distress and really are not going to produce any benefit. So it's important to understand what they've had implanted. Most people will have a a card of the type and contact either their cardiologist or the manufacturer, and most of these people are on call 24 hours and can usually do something about it to disable the device. This is probably the most important slide of all. It's keep calm. You are not alone. But also, I think, you know, if somebody dies overnight, you don't need to run around like a headless chook. You've got time, you've got support. You don't need to, you know, rush to ring ambulances or anything like that. It's important to, you know, predict this, explain to the family what's going to happen, and yeah, we're part of I guess GPs are part of a team that are providing community palliative care. So I think the people that we've got supporting us are fantastic, and of course some of them are on this talk tonight. After the death, it's important we live in a multicultural society to be sensitive to cultural and religious beliefs. Now, hopefully you've already got a sense of this, certainly for patients that you've known for a long time. Different cultures have different customs. Certainly working in palliative care, I've seen there are, you know, different custom rules around the time of death and what happens immediately after death. So obviously very important to talk to patient beforehand if you can, but also the family and how that can be dealt with. Palliative Care Australia have some good information on cultural sensitivity and different issues around death, so I definitely recommend that, and I'll send that through to Leanne. Funeral homes, it has always surprised me that often people haven't even thought, even though their loved one has got advanced malignancy or whatever, they haven't thought about funeral homes. So I you know, there have been cases, certainly in a hospice environment, where we're frantically looking for funeral homes and directing them. So there are lists on this website, after.org.au, but it's useful having that conversation. And certainly in specialist units, and again, Olivia and Emily will probably talk to this. We might get them to talk to this later. This conversation is used, you know, social workers will often have this conversation beforehand, talk to the families about what needs to be done. What do you need to prepare to get ready for death and what happens after? Because it's useful to have a funeral director lined up. Declaration of life extinct. This is a useful thing to be done during, you know, inverted commas, unsociable hours. And there are certain people that can do it. So registered nurses that have been trained, extended care paramedics. You still, as the GP, need to do all the formal certification, which I will talk about. But there isn't a rush. You know, the family can be reassured that they can stay with their loved one overnight. But, you know, it may be important if somebody's died in a residential aged care facility, for instance, Julian's probably seen this, they die overnight. Often there is a senior RN that can declare the life extinct. It depends. He's smiling. Or there may not be, but it's a useful thing because sometimes they will want to then take the body, get it to the funeral directors.
Is that what happens, Julian? Yeah.
We don't have RNs that can do it, but normally it'll be the next morning. Family might come visit overnight, and yeah, the GP will sort of swing around next morning. We're quite close, we're very closely located. So
oh, you're in the Barossa though.
Yeah, in the Barossa.
Yeah. So this is a declaration of life extinct form from Mary Potter Hospice. And it is interesting that the clinician, what is needed to verify death, I think is probably a bit more involved than most of us do. But what you are supposed to do is palpate the carotid pulse, listen to heart sounds for 2 minutes, make sure there's no breath sounds for 2 minutes, make sure there's fixed and dilated pupils, ascertain that there's no response to central stimuli. So that may be the common one that I think we got taught was the sternal rub, supraorbital pressure, the trapezius muscle squeeze, and so there's no withdrawal response or facial grimace. I mean, certainly in my experience, I don't sit there for 2 minutes listening to heart sounds, but you know, that is actually what you're supposed to do. Then it's certification. So why do we do death certificates? Well, it's an important legal document. It provides advice to births, deaths, and marriages. It gives authority to the funeral home to actually dispose of the body, which is critical. They are legal documents that are necessary for the determination of settling estates. And they importantly give the Australian Bureau of Statistics data on mortality, patterns of disease. So filling them out is important. One of the things that I certainly learnt, and it wasn't a pleasant learning experience, was you need to be very clear about what you write on death certificates. So family members will have access to them. And you do need to be clear about what the cause of death was, whether there are any significant comorbidities. If you write down, I did this with somebody that had alcoholic liver disease, and this came as quite a shock to the family from this sort of from their estranged brother, that apparently it then caused problems with them accessing insurance or something. So you've got to be upfront. It's not nice to have sudden surprises. I've had a couple of families over the years that have really been distressed by what's written on medical certificates. So who can fill out death certificates? So it's if you're the medical practitioner who was responsible for the deceased's care during their last illness, or you were caring for them immediately before the death, or you actually examine the body of the deceased. You've got to be comfortably satisfied as to the cause of death, and that there are no circumstances which require reporting to the coroner, and I'll talk about that in a minute. So if a regular treating GP is away when the patient dies, another GP from the practice can fill in the form. There's not an issue with that, as long as they've actually got enough information. It's actually preferable that they view the body, and if they have any doubt, they shouldn't complete the form. I think some GPs in group practices, of which we are all members these days, almost all, probably feel compelled to do something when your GP colleague's away for holidays. But if you're really not sure, you shouldn't complete the form. And it's ultimately based on your best medical opinion. There's some really good advice on cause of death certification, which is through the Australian Bureau of Statistics at that website. And I've also got a list of useful references at the end. And it gives a good overview of what sort of wording to use, because that is important. So I'll just quickly run through this example of a death certificate. But presumably you've all done these multiple times, so I won't get bogged down. So this is a 78-year-old completely fabricated patient called Joe Bloggs, who's not Aboriginal or Torres Strait Islander, diagnosed with metastatic non-small cell lung cancer in May 2017. He's got a history of type 2 diabetes. He's got ischemic heart disease, and he's had a previous MI with coronary artery stenting, as well as a pacemaker and various other chronic problems. He didn't respond to immunotherapy and cytotoxic chemo, proceeded to palliative care, and you cared for him as the GP. He increasingly developed shortness of breath, weakness, and progressed to the terminal phase, and successfully had his end-of-life care in the home, and he died peacefully at home at Springfield at 7 a.m. and you visit him at lunchtime. So one of the things to say about time of death, if somebody has been with their loved one when they die, that is good enough. If there's a nurse with them, obviously that's good. We accept what they say. You don't have to, it's not when you see them, it's when the death has happened and you're comfortably satisfied that that's a reasonable thing. So I guess there's a few things here. These cause of death certificates, the sex or gender identity has changed a little bit in the last couple of years to include non-binary and indeterminate. You've got to make sure that you record whether they're Aboriginal or Torres Strait Islander. Obviously the age of death, the date of death, the place of death, whether or not they've got a pacemaker is important. And then the condition that led directly to the cause of death was, in this case, the metastatic cancer, and then any other significant conditions and durations. Now, obviously, he had a lot of other problems, but you could argue that potentially having ischemic heart disease and type 2 diabetes contributed, but you don't have to do that. If you're uncertain, you think that's not that important, you don't have to put that there. It's, again, it's your best guess. All right. So what do we do with certificates? And hopefully we'll all be familiar with this. It's in triplicate. The white copy, I think importantly, has to go within 48 hours of the death. You do not give this to the funeral director, and there's the GPO box address for the Registrar of Births, Deaths and Marriages. The yellow copy is given to the funeral director, and then the blue copy is supposed to be retained by you as the doctor. So when don't you issue a death certificate? When are you thinking about contacting the coroner? Again, this is not necessarily relevant to those in palliative care, but however, I thought I'd go over it. So violent or unnatural death, sudden deaths of unknown cause, death under suspicious circumstances, people in custody. If, as I said before, you're not reasonably comfortably satisfied that you understand what has led to the death, then that's enough reason. And I've put down the bottom, ring the coroner. The coroners, in my experience, are available. They are fantastic and they're very helpful, but I think they usually err on the side of caution. So if you're really not sure, ultimately they'll tell you not to issue a death certificate, and then they take it, even though they're very, very busy, obviously, then it'll become a complicated issue through them. And then it's really communicating well with the family that you don't really know what's going on. In the situation of palliative care, we 99.9999% know what has gone on. So it is a bit different. Within, or as a result of, say, 24 hours of administration of an anaesthetic, during a medical procedure, that usually means, surgical procedures, and there's quite a lot of simple procedures that are not included in that, and I'll go through that in a minute. Or death following a medical procedure where the death was not reasonably expected because of the procedure. So that might be a thing like a colonoscopy. You wouldn't expect somebody to die because of a colonoscopy. So that would be something you would want to refer. So things that you don't need to worry about are, and probably the most important is CPR. So you don't need to make it reportable if the person said CPR in the last 24 hours. IV injections, urethral catheters, subcutaneous injections, ear syringing, acupuncture. I mean, I know some of these seem a bit laughable, but they're not, the coroner doesn't care about these kind of things. And I suppose CPR is important, and it depends on what the context is, I suppose. Again, it goes back to you have to be comfortably satisfied as to the cause of death that you're going to write on the certificate, because it all falls on your shoulders, basically. So the burial and cremation forms that we GPs use are Form 3, that's the longer, it's a slightly longer form for cremation, goes into a little bit more detail about the cause of death and associated medical problems, but it's pretty similar to the form that I showed you that we all have to fill in. Then there's the second, as we call it, which is usually a colleague will look at the death certificate and the cremation certificate, and as long as they're happy, they'll sign it. Then Form 6 is relatively new, it's a very simple little form, and that's for burial. And Form 7, which is a certificate of identification of deceased, it's actually quite important. You cannot bury your cremated body unless a certificate of identification has been cited. So what is supposed to happen is there is supposed to be a identification tag on the secured to the deceased before the body can be moved. Now, I'm not quite sure that always happens from home. It's supposed to happen. I suspect who does it is the funeral director probably, but in a nursing home, I think it is usually done. Certainly in a hospital, it's usually done. But this was something that I found a bit surprising, which is why I've included it as something that's important, got to be a responsibility. So it's got to be legible, name, place, and preferably left arm, so left wrist, they normally put it on. We are rapidly reaching the end here. so to speak, that wasn't pun not intended, but Atif has pointed out that is quite a good pun there. Some extra tips. I think if you're in a hospital, which will not be most of us, and there's a plan to discharge somebody to die at home or aged care facility, it's really important, because I talked before about, if you discharge somebody within 24 hours, that's normally a reportable death. But if the situation is of advanced malignancy and it's an expected death, it's better to advise the coroner that this person is being sent home to die, and that there is an expectation that they could die within 24 hours, and then you don't need to go down the coroner's path, which is not very pleasant. Here are some useful resources. These are fairly broad, and we talk about these a lot. I think therapeutic guidelines is only up to version 4, but Emily and Olivia might tell me differently. It may be up to version 5. Care Search has got lots of information on this kind of stuff. The Palliative app's very good as a decision assist tool. There's lots of opioid conversion calculators out there. Always think about your local specialist PAL care service, and we've got all their numbers on the website. If you want further information about filling in death certificates, there's the link there. And this is quite old now. There's a really good article in what used to be called the Australian Family Physician in 2011. This is readily available from Sarah Bird, who's a medico-legal sort of guru. That's worth looking at just to refresh any questions you may have. And there's my medical hero, Nick Riviera, who I doubt would prepare any of these things like I've just suggested. So there you are. Thank you very much. Now, have we got
maybe from Olivia?
Okay.
Yeah.
I might stop sharing. I need to get it back. Where's my Zoom? Okay. Stop share. Okay. So thanks for listening to that, folks. And we'll just have a look in the chat. Oh, there we go. Are there any questions that anybody wants to ask now? So Olivia, did you have something that you wanted to say or ask?
Oh, no, I thought that was great, Russell. I just thought that I would mention that if a palliative care patient does discharge from hospital and does die within 24 hours, as you quite rightly said, it is notifiable to the coroners, but it's a much shorter form. So there actually is a separate form, which really spells it out quite clearly. And I often find that the coroner will be willing to hear it ahead of time. And so I have called and said, I'm sending this person home. There is a high risk that they will die within 24 hours. This is expected. And they'll send through that paperwork, and it is sort of a single sheet really to fill out. So not as laborsome if anyone's done any of the other coroner notification.
Fast track coroner assessment, basically. I've never actually happened in my experience, but I know, you know, certainly Laurie Palmer, when I was doing this talk, I talked to Laurie, said, you've got to put that in. That's really important. Like, it's, you know, if you guys, send them out to die at home, make sure you pave the way and it doesn't become all messy, because that would not be pleasant.
Yeah. And just letting know the families, if there is risk of it being notifiable to the coroner, it does sort of slow things down, but not significantly, I don't believe. And, you know, thanks for putting in that list of what is notifiable to the coroner. And I think the thing that always I like to double check if anyone's under a SAPS order. So even in the community, and they can sort of sneak up on you and take you a little bit by surprise. So I am often just ringing SACAT, confirming sort of guardianship orders, and then letting people know ahead of time that just because of that fact that it is a notification to the coroner.
Yeah, that's really good advice. Thank you for that. Any other questions from anybody? No. I tell you what, so I might get Emily to.
Yes.
Yeah.
Before you do.
Yeah, Emily, are you happy? I've sort of organised a bit of an amalgam of a case based on various people that I've seen over the years that I might present in a minute, because unfortunately we didn't get any cases sent in to Naomi or Leanne. Do you want to have a little chat about what you're doing at the moment?
Yeah, sure. So it's a bit off of this topic, but thank you for having me. Part of the Southern Adelaide Palliative Service, we have regular continuous improvement projects, and the one that we're running at the moment is regarding the way we manage medications. So under our palliative care service, we do have sort of hundreds of patients who are under joint care between us, specialists, and often their GPs. And we may be doing sort of home visits, or they may be coming to our clinics. And we find that a lot of the patients under our service ring our nurses and request follow-up prescriptions for some of their routine medications. So it may be for things like their extended release opioids, so things like OxyContin or MS-Contin, and it may be for breakthrough medications like endone or oxycodone. It can also just be for antiemetics and other medications. What we find as a service is that it's really quite burdensome for us to be able to properly attend to all these scripts. We also feel like we're doing some of the patients a disservice if we're just providing sort of faxed out scripts without a proper review, putting people at more risk of getting duplicate prescriptions, or perhaps then doctor shoppers diverting some of the medications that we provide. And so we worry that it's a very sort of inefficient system, and that perhaps some of our patients are becoming a little bit disengaged with their GPs, whether it's, you know, when they've been diagnosed with cancer and then they're with their specialists and seeing them so regularly that they're not booking in to see GPs. We're not exactly sure what's happening. So we're doing a continuous improvement project to, I suppose, properly understand why we're getting so many requests for scripts. And part of that process is to ask all of the different groups of people who are involved in this. And we think that GPs are obviously a huge part of this. Like, you are obviously the main port of contact for all the patients with palliative diagnoses. And so we'd really value if you could do our survey that we've had Leanne send out to you all. It's very quick. It's just on SurveyMonkey, and it's got a combination of just clicking the boxes, but also some free text in case you have any other insights. because we're wondering if, you know, maybe part of it is that, you know, you're not getting good enough correspondence from our services, that perhaps you're not entirely sure what patients are meant to be on, or whether there's some reluctance to get sort of increased quantities if patients need authority scripts, or, you know, whether perhaps sort of lack of familiarity with some of the medications that we prescribe, or whether it's the poor remuneration that you're unfortunately getting from the government to do things like home visits and telehealth reviews. Yeah, so we're not sure. They're, I suppose, some of our ideas. And I mean, if anyone was happy to have just a short discussion now, if we had time as well, I'd really love to hear from you, Russell, or anyone else, your perspectives. Otherwise, we'd just love to have some responses to our survey.
Yeah. Well, certainly, we'll do the survey.
Yep.
And so, Leanne, you've sent that.
I've sent that out, but we'll also make that link available via the website, and we're about to send out a newsletter, so we'll incorporate that in the newsletter for Emily and her team.
Yeah, I think it's interesting. I certainly had seen this before on and off, working, you know, as a GP or a medical practitioner with palliative care services, having to do this years ago, like, because I think often patients and their families find palliative care services very nice, very approachable, and they kind of feel like, oh, I'll just go to you. And their GPs, especially these days, much harder to engage with. They're busier, their books are full, they're going to be charged if they do a telemed appointment, all those kind of things. So very useful thing to do. But you're right, it should be, I mean, we should be doing that as GPs.
I think it's just that balance. Like, we do want to be accessible and really, you know, help embrace our patients, but we just feel like we can't do a proper service to sort of the numbers that we have on our books. And yeah, that's why we're really curious to hear your perspective, but also very sympathetic to, you know, especially since COVID, it seems like it's hard to get an appointment with any GP. Everyone's run off their feet and
burnt out, and but there's lots of dynamics that are out there at the moment. There's
exactly
unhappy primary care people. So
and obviously if you get a phone request for a script, I presume you still can't bill at all, so that's all work that you'd be doing in your own time, which also is really difficult.
It's a useful thing to do. Now, who have we got? Now, there's a few GPs online. Any of you guys have any thoughts on this? Anything you'd like to contribute? Or maybe even put something in the chat if you want to. And if not, I'll give you a couple more minutes, even if you want to put something in the chat. But if not, what I'll do, you can always look, even after these sessions, you can send questions in to Leanne, and I'm happy to respond to stuff. And you know, if I'm not too sure, I can get Olivia to help out, or, you know, Julian or Andrew, depending on what the nature of the question is. So any time, if you're wanting some clarification about a tricky palliative care situation, please let us know. So normally what we do in the next part of this little Project Echo presentation is present a case. So what I've done is just very quickly, hastily, created one. We created it for last time, but didn't end up using it. So I'm just going to share the screen, and it's got elements of patients that I suppose.
Russell, I think it was a fabulous comment just before we.
So thank you everybody for joining us in this final Project Echo of the year, and hoping everybody has a be safe and happy Christmas. And I'll hand it back to Leanne to talk about what Project Echo is going to look like in 2023.
Okay, so I'm just trying to share my screen, but not very successfully. Just to bring that last slide up.
Oh,
so obviously We are coming to the end of 2022 and our project extends then into 2023. The first session back is the 18th of January. So we look forward to having you all on board for that again, and I'll be sending out the link to join that session. In the meantime, there's a lot of information that's come out tonight, even though Russell probably didn't think it might when he started his presentation in terms of links that we'll be able to put up on the website that hopefully will assist you all. So I'd just like to take the opportunity on part of our team, the panel, to wish you all a very safe and Merry Christmas. And we look forward to seeing you back next year on the 18th of January. So take care.
Bye bye.
Bye bye.
Thanks, guys.